I've started it. Yeah. So we are looking at the bug, a bacteria, a virus, any microbe which has to enter and then multiply. That multiplication is most important, because unless there are enough number of them, they will not be able to cause any damage. The thief has to enter and has to exploit the situation. So what does the thief do? Thief invades, enters your room, maybe through respiratory tract, maybe through gastrointestinal tract, maybe anywhere else. But for today's case, we'll consider as entry through respiratory tract. So it enters and it may stay there itself, in the balcony, maybe in the gallery, maybe in the porch of your house, or it may from there enter into the drawing room, maybe go to the maybe go to the bedroom, maybe go to your study, maybe go to attic, maybe go to basement, wherever, contiguously, wherever it is. So once it enters, it can go contiguously, or it can pick up some other route and go to some other places to cause systemic spread. So we may find the bug locally, or sometimes it may disappear from there, go to some other site which is contiguous, or it may go to a distant site also. Now, why do we need to know this is because when we are looking for a particular bug, we need to make sure that we get that bug from the place where it is most likely to be present, and most likely to be present at that particular time. If you're collecting a specimen, as soon as the bug is likely to have entered, you should pick up a local specimen. If you think it might have traveled, enough time has passed, you need to collect it from some other contiguous place. Or if you think it might have invaded the bloodstream, maybe you'll have to collect the sample from entirely different place from the respiratory tract. An interesting example is the diagnosis of Legionella infection is done by analyzing urine. Isn't it interesting? Legionella enters through the respiratory tract, causes pulmonary infection, leads to interstitial pneumonia. But to diagnose, we collect a urine specimen of the patient and find out from there whether the bacteria is present or absent. So such things we can do only if we know what is the route and how the bacteria or how the virus or how the bug is likely to travel. So a thief has come into your room. It has perhaps stolen something and you have woken up. What will you do? You will shout. You will raise an alarm. You will call for help. Depending upon whether you have just seen a shadow entering into your room and shadow disappearing, or you have actually seen and identified the person, your raising alarm and calling for help will depend. So you may raise alarm or you may call for help, which might be non-specific alarm, non-specific call for help, just saying, hey, who is there? Someone come and help me. That's a non-specific. But if you have identified, if you have seen, then your response might be specific. Hey, Mr. So-and-so, why are you here? Now that becomes a specific response. Our body responses also are non-specific or specific. So to solve the case, whether there is thief or no thief, whether theft has occurred or not, and who has stolen, Sherlock Holmes has to collect lots of evidence. And it has to be proved in the court beyond doubt. So first and the foremost thing is to prove that there has been theft. If we can't prove that there has been theft, we cannot say that there is a thief. So for we to say that there has been theft, we need to first confirm that there has occurred some disease in our body. That disease has to be defined in terms of anatomical location. Was it rhinitis? Was it sinusitis? Was it pharyngitis, tonsillitis, or was it pneumonia, or pleural effusion, or pleuritis? So we have to first make an anatomical diagnosis at so and so place infection has occurred. Then we have to also make, to some extent, what theft. So we also have to say that there has been a theft or there has been damage done to the property. That is shown by loss of function. So when some organ is infected, diseased, there will be obvious change in its function. So to prove theft, to prove clinically anatomical site of disease and the pathological lesion which has occurred. These two things must come in our mind, and that comes by clinical history and by examination of the patient. Now we have established that a crime has been committed. Next job is for you to catch the thief. And once you catch the thief, to try and recover the property which he has stolen. Not only that, but you also need to think that the thief should be punished in such a way, or actions must be taken in such a way so that such theft does not recur. When we put it into our medical parlance, we have to prove that the disease has occurred. We have to catch the infective agent which has caused this, and we have to try to restore the function and structure wherever this bug has caused infection, and also to take precautions to prevent recurrence of that infection. And that prevention could be many ways. The community medicine people would have told you primary prevention, secondary prevention, tertiary prevention. So various ways in which it can be done. Now you are Sherlock Holmes. You are at a site where the theft has occurred. You need to collect appropriate evidence from there. So first and foremost, you need to take case details. You need to ask the people, ask the patient the detailed history. The detailed history includes everything: the demographic history, the age, the gender, the occupation, the personal habits, the family history, genetic history. So many things will be there, including the present illness, past illness, past treatment, past vaccines. All those things come into the clinical history. Those details we need to obtain. And once we have obtained the detail, we need to go and collect the specimen from the particular site. And this is where we need to understand each disease in its details to be able to predict that at this particular time, at this particular phase in the disease, the organism is most likely to be present at this particular site. Many of the organisms will move in different parts of our body at different times. So if it is on the day on which infection has occurred, we might organism at one place. If it is after 3 days, we might pick it up from another. And that way we need to pick up which particular site. Should it be nose? Should it be throat? Should it be saliva? Should it be aspiration from the trachea or bronchus? Or should it be sputum which is coming from the lungs? So many samples can be collected based on site from where we need to collect it. When is the best time to collect sample? As early as possible. Before someone else comes and tramples on the evidence over there, contaminates the evidence over there, you need to collect the specimen. So time to collect is before you start any treatment. Particularly before you start any antimicrobial treatment, you should collect the specimen. How much specimen to be collected? This will be determined by which type of a test or number of tests you want to do on that specimen. Please remember, every specimen is very, very precious, because you cannot obtain that specimen again. You may say, oh, what's the problem? Urine sample, if I can't obtain it right now, I'll obtain it after 2 hours. No, it will not be the same urine sample. In 2 hours, many changes would have occurred in body. Medications could have been given. Medicines which have been taken could have got absorbed. They would have peaked their level in the urine and blood, and you may not find the organism. So every specimen is very, very precious. You cannot get that specimen again. Therefore, you need to time and determine the quantity of the specimen. Obtain it at one go, as much as you need, or little more than that, so that in case you remember, oh, I need to do that test also, you will have some specimen in reserve with you. How to collect specimen and how to preserve specimen, how to transport specimen will all depend on what type of a investigation you are looking for and what type of a specimen you have collected. Some specimen may require storage in the cold, some specimen may require storage at room temperature, some specimen require storage in incubator at 35 to 37 degrees centigrade. Some specimen may last few hours, some specimen may last few days, and some specimen can be kept even for weeks or months before transportation. And the temperature and the other conditions of transportation and preservation have to be specified with each type of specimen. So when you will be studying each disease, we will tell you about all these things about specimen. What time the specimen should be collected, how much quantity should be collected, how it should be collected, how it should be preserved, and how it should be transported. And once you transport it into the laboratory, what processing you want from that specimen. In other words, you can't simply send a throat swab to the laboratory and tell them, I want a diagnosis as to what is causing fever in my patient. May not be really appropriate because there could be 10,000 different causes of fever and laboratory will not be processing one sample or 10,000 different tests. You have to be a little more specific, little more considerate, little more narrowing down your possibilities. So you need to say, I am expecting a case of group B streptococcal pharyngitis. I have taken a specimen of throat swab and I would request you to look for group B streptococcus. Maybe there might be Haemophilus also, or there might be some staphylococci also. Okay, you have narrowed down the possibilities to 2 or 3. Now the laboratory can work into that area and see what is the most likely cause. But you can't say, take this specimen, run it for all 1,000 viruses and 10,000 bacteria and 20,000 fungi and tell me by tomorrow what is the cause. Sorry, that way it does not happen. We have not developed that technique. Now some techniques have been developed in that particular fashion, which is called as a multiplex PCRs, where you put one drop of the specimen and run for all possible genetic material which could be there. But what is going to happen over there is, even if a smallest quantity of genetic material of an organism is there and large quantity of genetic material of that organism, there won't be any distinction as to which is more likely to cause disease. You'll get a list which will say, okay, 20,000 different microorganisms could be their cause. You are left with guesswork. So be specific when you ask what process you want in the laboratory to be performed. So let's look at the 4 important principles of laboratory diagnosis. First principle is demonstrating the pathogen. Whether some pathogen was there, is there, or was there or not. Isolating the pathogen, the best way, catching the culprit. Or sometimes it is not possible to isolate the pathogen, then you may demonstrate it response to that pathogen and may conclude that because there is this response, there must have been this particular pathogen causing the disease. And based on this, we can offer treatment and offer protection. So let's look at the first principle. Specimens, which this we have already discussed. For upper respiratory tract and for lower respiratory tract, we collect different types of specimens and different ways, methods of collection of these specimens. But once these specimens are collected, the techniques for diagnosis remain more or less same. First and foremost is demonstrating the pathogen, saying that there is or was a pathogen in this particular specimen. Either showing that specimen is having that pathogen or showing an evidence that pathogen perhaps was here or perhaps is here. Now this perhaps is something which we need to understand in laboratory diagnosis because it's very ambiguous result. But if we need to demonstrate pathogen, once we have taken the specimen, what we do first and foremost is make a smear and stain it to identify if the pathogen is there based on its morphological structures. We are not naming the pathogen over here, but we are making the guesswork that if it is a coccus, if it is a gram-positive coccus, if it is a gram-positive cocci which are arranged in particular fashion, then most likely these are either staphylococci or streptococci or pneumococci. Nothing more than that. We are always making the possibility. And to do that, we do either a light microscopy where we use different types of stains, gram stain, Zn stain, gsmc stain, and so many stains. You will learn about each one of them when we do a particular study of particular microbe. We can do a dark field microscopy to demonstrate the transparent organism which cannot be stained well, which are very thin. Another microscopy is phase contrast microscopy, but these both are not so much in practice these days. We have started relying more on fluorescent microscopy, where a fluorescent dye is added to the specimen, and that if the specimen contains that particular microbe, it will fluoresce. An example is Mycobacterium tuberculosis. It gives fluorescence with rhodamine or amine stain. No other bacteria gives such distinct fluorescence. So we can identify it by fluorescent microscopy. And for research purposes, we do electron microscopy where we can see the ultrastructure of the organism, and based on its ultrastructure, we can make a tentative diagnosis. So what do we see in morphology? Well, morphology is something like the identification parade which is held by the police. You complain to the police that theft has occurred. People they pick up randomly 3, 4, 5 people, and they have suspicion on one of them, but they are still not sure. They want you to identify if you have seen the thief. So they do an identification parade, and based on your information, they will try to see whether the thief is same or different. And how will you respond? You will respond by their morphology, by their height, by their approximate weight, by the shape of their face, by the position of their ears, by the color of their eyes, maybe by their hairstyle, but they may change their hairstyle, maybe based on their clothes, but they may change their clothes. So similarly, when we do a microscopy, we look at the bacteria's size, shape, staining characters, their arrangement, the way they walk, motility, and which particular type of stains they take or they don't take, whether they are gram positive or negative, or they're Zn positive or negative. Based on these morphological features, we can make a tentative diagnosis that, okay, this is the pathogen. But it's again tentative. Now, sometimes you may not find the thief over there, but you may find evidence of the thief having been there. So what you do? You collect fingerprints. You collect shoe marks. You collect hair which have fallen over there. You collect some skin scrapings which might have fallen over there. So you try to collect the footprints or evidence that some part of the thief, maybe his handkerchief, maybe his pen, maybe his name tag, maybe his glasses, they will act like his visiting cards. So for microbes also, we try to pick up their footprints, not the whole microbe, but some component of the microbe in terms of antigens or in terms of their cell components, which are picked up by molecular techniques like PCR, or in terms of their hankies or toxins which they have left back over there. So presence of an antigen, presence of other cell components, particularly the DNA or RNA, or presence of the toxins in that particular location tells us that this particular pathogen was here. It may not be there at that time, but it has left telltale marks of its having visited that particular site. Now you have collected these fingerprints. Does it tell you that this person has done the theft? No. It only tells you one thing, that person has been in this room because his fingerprints were found over there. That person could have come before the theft has occurred, person could be there during the theft, or person could have come after the theft has occurred. Person might be involved in theft, might not be involved in theft. All things are possible. So similarly, presence of a bacterial or a viral antigen or presence of their genome as RNA, DNA, or presence of anything else like toxins does not tell us the disease is caused by that particular person, but it only is an evidence of their presence. They have been there. It does not tell us whether this organism is pathogenic or non-pathogenic. Whether disease is caused by this or not, we do not know. We can make a tentative guess that if the clinical features of the disease are in this particular format, and we find this evidence of, say, presence of genome or presence of antigen or presence of toxin, we can say because these clinical features can be caused by the things which this organism could have had, this toxin. So most probably this toxin producing organism is responsible for this disease. But it's again assumption. It can have some amount of predictive value that if you do a gram stain or if you do PCR, you are still waiting for culture report to come. But by looking at that, we can say, oh, I found gram-positive cocci in the clusters in large number of in this particular nose swab. So tomorrow when I look at the blood culture plate, I'm most likely going to see staphylococcus. So you can have some prediction as to this might come out in the next test. But just presence does not tell whether the organism was alive or dead. You could have picked up an antigen from a dead organism. You could have picked up RNA from a dead organism. And if you see these days, particularly in response to COVID, we are seeing large number of patients are coming out to be test positive by PCR, but organism does not grow from their swab because RNA is present, but it doesn't have the complete virus to cause the infection. So that person may not be infective, might not have got infected because the organism was perhaps dead, not alive. So that is the disadvantage of direct demonstration of the presence or absence of the organism. So we need to keep these things in mind when you are in puberty. Now, after that preliminary study, Sherlock Holmes gave some clues to the police, and police went into hunt, and they found this particular man loitering somewhere near the site of theft. So they picked him up, saying that we were told by Sherlock Holmes that the fellow who has conducted the theft is most likely a bald fellow, clean shaven, no mustaches, fair, has by his appearance he might be wearing a black colored shirt and a trouser which is light colored. That is a description which is given by microscopy, and based on that they have picked up this particular fellow. But is he the thief or not is yet to be decided. So what we need to do is we need to isolate the pathogen, and that isolation we do by culture techniques. So by microscopy or by demonstration of PCR or by antigen or by toxin, we have had some idea that this is most likely pathogen. Now we need to isolate the pathogen. So again we need to collect the specimen from where we can isolate the pathogen. That specimen could be same or similar specimen which we have collected for demonstration, or could be entirely different specimen. Once we understand the disease process, we'll understand which specimen we should take for isolation and how we should process that. So you have collected a specimen, maybe you collect a specimen of sputum or maybe a throat swab. Now we need to put that specimen to show that the organism which is present over there is capable of multiplication. In other words, the organism is alive, can multiply, can increase in number, can acquire that important number at which it becomes disease producing. And that can be done by various methods, by culturing in vitro, in culture media, maybe blood agar, maybe chocolate agar, maybe McConkey agar, maybe any other media, or we can do it in animals, in mice, rabbits, or any other animals, or sometimes we can do it in tissue culture or cell cultures. In vitro tests are all done in artificial media. Now, this artificial media is very good for growing bacteria and fungi, but not good at all for growing the viruses. For them, we'll require tissue culture or cell culture. But mice, rabbits, animals, we can use for both viruses as well as bacteria or fungi or parasites. But problem is, it is not always necessary that the organism will grow in mice and rabbit, because mice and rabbit will also have their own innate and adapted immunity which might resist this. So not very good. Also, it's a costly, it requires lots of laboratory facilities, and these days because of PETA, what is PETA? PETA. Anyone knows about the organization called PETA? PETA? People for Ethical Treatment of Animals. PETA. They do wonderful work as to how we should treat animals also with respect. So PETA has put lots of obstructions on using animals for routine culture when other methods are available. So we should try to use simpler other methods for diagnosis. Now, in a culture plate or in the tissue culture or in the embryonated egg, we have grown a particular organism. We have done a gram stain from there, or we have done other tests from there and have identified that this is organism named so and so, maybe Streptococcus pneumoniae or Staphylococcus aureus or gonorrhea Neisseria gonorrhoeae or whatever, or Mycobacterium tuberculosis. Can we say with confidence that this is the thief? Well, you have caught the person as per description, but you still have to prove that that person has committed the theft. Now, it's easier if we know that the bacteria or the organism which we have isolated is a known pathogen. Like if we isolate Mycobacterium tuberculosis from sputum of someone, it's a known pathogen. It's not a commensal. It does not normally stay without causing disease in anyone's body. Therefore, we can say that it is pathogen. So, a known pathogen is easily identified. Problem comes when it is a probable pathogen. That means it could be a commensal in our body, but today it might be causing disease. That happens in case of Streptococcus pneumoniae. Streptococcus pneumoniae can be a commensal in the nose, can be commensal in the throat, but when obtained from the lungs in a sputum, it becomes a pathogen. So we need to know what is the normal flora of the body and where we have taken the specimen from there, and is it a probable pathogen or is it a most likely pathogen from that particular specimen. It also depends whether we have got a pure growth of that bacteria or virus or we have got a mixed growth. If you have got Staphylococcus, Streptococcus, Haemophilus, and number of other organisms growing together in a plate, it is very difficult to say which one of them is pathogen, because all of them can be commensals, or one of them could be a pathogen, all others could be commensals. In that situation, we need to work also on the growth. If pure growth is majority of the growth is of that bacteria or that virus, then we consider that that must be the pathogen. Also, we need to work out virulence factors of this particular organism, and are these virulence factors important in clinical presentation which we have seen in the patient. An example is, let's say some patient suffers from throat infection, some problem over there, finds difficulty in swallowing, goes into respiratory obstruction. What is the most likely clinical diagnosis coming into that? Any guess? Someone who has got respiratory obstruction is not able to breathe because of some infection. What is the most likely in a child? Any guess? Anyone having heard of such a disease where there could be respiratory obstruction? Okay, for you to find out, because our subsequent classes will deal with this topic. So if that particular type of clinical presentation can occur because of the virulence factor which is present in the organism which you have isolated, yes, then you can call it as a pathogen. So we need to establish pathogenicity and virulence factors of the organism whenever we isolate that. So much for identification and establishing that yes, this is the pathogen. We can use this knowledge subsequently so that we can do an antibiotic sensitivity or drug sensitivity to see as to which drugs will be most effective in this particular patient. So here we can extend our study of isolation into therapeutics as to what treatment should be given. We can extend that isolated organism study into epidemiology. Is this organism same or similar to the organism isolated from many other patients? Yes, then it tells us epidemiology that this virus SARS-CoV-2 is causing infection in so many thousands and thousands of people every day, because we are showing the epidemiological proof of that. It also helps us in follow-up and in research on this organism, and also in devising ways and means of prevention. Today we are on the verge of having a vaccine to prevent COVID-19. How has that stage come to? Because we could isolate the pathogen SARS-CoV-2 virus, we could study that virus, we could do enough research on that virus, and we could make the vaccine which will give protection against that. So isolation and identification of organism are extremely important. Next comes is response. How do the body respond to this particular invader? There could be non-specific response in terms of increased TLC, increased WBC count, maybe pulmonomorphonuclear response or lymphocytic response or eosinophilic response or increase in C-reactive proteins or increase in ESR and so many other markers which could be there which are non-specific. That means in number of diseases, same changes can occur. Or there could be specific response like increase in the antibody titer. So we can take specimen to see our body's response, and these specimens could be, if we are looking at non-specific response, as the inflammatory response, tissue response, cytokines, cytology or histopathology, these will show us non-specific response. But if you are looking for non-specific response, we must understand that one type of response can be produced by multiple causes. Like increase in TLC can occur because of streptococcus infection, staphylococcus infection, Haemophilus infection, pneumococcus infection, many of them. So many causes can cause one response. Also, many responses can be seen by one cause. So a streptococcal infection will lead to increase in the WBC count also. It will lead to polymorphonuclear leukocytosis. It can lead to increase in ESR also. So multiple responses can be seen by the same organism also. And what does it tell? It does not tell us anything about organism. It tells us that our body is responding to some insult. That means some insult has occurred in our body. But sometimes we may not see any response if the patient is non-responsive. If someone is mute, if someone is blind, if someone is deaf, then someone enters in that person's room and picks up a stuff. That person may not notice, may not respond at all. So non-responsive patients could be there where innate immunity or adaptive immunity may not respond. Or there could be patients who might be hyper-responsive. There might be just a cockroach walking on the floor somewhere, and there could be a response as if there has been a horde of snakes. So that also could be there, and sometimes there could be misdirected response. These two things, hyper-response and misdirected responses, we studied when we studied about immunology in terms of hypersensitivity reactions and in terms of autoimmune diseases. So when we look at the responses, we need to keep these points in mind and interpret the value of that particular evidence. So specific response could be production of an antibody, IgM, IgG, IgA, etc., or cell-mediated immunity. But we also need to understand, is it specific or is it misdirected, as it occurs sometimes in hypersensitivity reactions or autoimmune diseases. If we show a rise in antibody level, what does it tell? It does not necessarily mean that the infection has occurred just now. It could be a past infection, it could be a vaccination, or it could be a present disease. It only tells us that antibodies are produced in response to the antigen which was presented in the cells. So it is only tells us about past exposure. It only tells us that immune system is functioning. Yes, but sometimes by detecting how high is the titer, how severe is the response, and how long the response lasts, we can predict that this response is due to present infection and not due to past vaccination or past infection. And this helps us in giving a probable diagnosis that if antibodies against a particular antigen are present, then our diagnosis is that person probably is suffering from the disease by the organism which has that particular antigen. So this is very important in understanding specific responses. Specific responses help us in follow-up of the patients. You take the specific response right now and you take it after 10 days. If you see that the response is increasing, that means most probably the pathogen is still in the body. If you see the response is decreasing, you can say most probably the body has got rid of the pathogen and that's why the immune response is decreasing. So follow-up is very useful when we are looking at the interpretation of specific responses. So far we have seen different methods: demonstration of the organism, demonstration of the footprints of the organism, isolation of the organism, and looking at the body's response to the organism. So these are the 4 important steps for diagnosis of any disease: respiratory disease, gastrointestinal disease, CNS disease. If you have understood these concepts, you can apply these concepts to a particular situation and learn about diagnosis. So to establish an etiological diagnosis, you need to select appropriate investigation. Do you want to do an investigation to demonstrate, or to culture and isolate, or to show body's response, or to show the footprints of that organism? Which particular investigation you would like to do? And for that investigation, you need to collect appropriate specimen. Now, when you send a specimen to the laboratory, please understand how much time it normally takes for this test to be conducted. We need to understand that just demonstration may take maybe few hours time. Antigen test may take 15 minutes to few hours time. Serological test may take couple of hours time, but a culture may take 2 days time or sometimes 2 weeks time. So when are you expecting the result? Because that result is going to modify your treatment and management. So which investigation will you like to interpret first, to monitor your test, to monitor your treatment, and to cure the patient? We also need to look into cost and availability of the test in our situation. All tests are not available everywhere, and all tests are not affordable everywhere. So we need to select the most suitable test for our patient, which the patient can pay for and should be available to him, and then interpret that result to understand what must be the disease cause. You will face these problems often enough when you will be looking at the patients in outpatient department or in the ward, and you will come across lots of doubts. So whenever you are in doubt, pick up a phone, talk to your microbiologist, walk down to the laboratory, consult the microbiologist and ask, I have got these results, my tentative diagnosis is this, can you help us in interpreting and finding out what is the most likely cause? Asking for help does not mean that you are weak or you are less intelligent or you are less worthy. It only tells that you do not know something, you have got a different view, and you need to consult someone to get someone else's opinion. Asking for help is not a sign of weakness. Asking for help is a sign of an open mind to be able to change your thoughts based on the evidence available. So don't hesitate in life asking for help anytime. You'll always get benefits. How to take that help is up to you to interpret and understand. So that brings us towards the end of today's session on diagnosis of infectious diseases, particularly respiratory infectious diseases. I hope if you use appropriate tools, you will hit the bull's eye and come out with the diagnosis most of the times. I won't promise you will be able to make 100% etiological diagnosis. So far it has not been possible. We are day by day improving our techniques to come closer to that 100%, but we still are in the range of about 60 to 80% of diagnosis in most of the cases. We'll stop here, and from next session onwards, we'll be discussing about specific diseases or specific microbes which cause those diseases. So any doubts up till now? Any questions to anyone? If you have, please feel free to ask those questions. We'll be happy to answer them. Let me know if you've got any doubts, any questions you would like to answer right now, or maybe you can even ask them afterwards in the next class, in the subsequent classes, or maybe you can mail or you can put up into your chat about whatever doubts you have. No doubts? No questions? Okay, so maybe we can wrap up the session today. Thank you very much for your patient hearing. We will close today's session and hope to see you next week sometime. Bye-bye. Take care. Stay safe.
Thank you, sir.
Thank you, sir.